Bismillah ar-Rahman ar-Rahim. Welcome to this session. We are going to continue our talking about ECG. This is the second lecture. Last time we talked about the PQRST format of the ECG. And we say that the initial positive deflection in the ECG is the P wave, and this is the P wave. Look to the normal contour and the duration of the P wave. And the first negative deflection, we say that the Q wave, this is the Q wave. This is the Q wave, which is the first component of the QRS complex. So this is the QRS complex. And this is the R wave. If you look to the R wave, this is the R wave. The R wave is the first positive deflection after a negative deflection. This is the R wave. And this is the S wave. This is the S wave, the last component of the ECG, which joins the ST segment at this point, which is called the J point. So this is the J point, and the J point is the point in which the S wave join the ST segment in the ECG. And this is the ST segment, starts from here to here. And usually in the normal situation, the ST segment lie together with the isoelectric line, which is PQ line. This is called the isoelectric line, PQ line. In a normal situation, in a normal ECG, the ST segment usually lie in the same line. When it is elevated above this PQ line, we say there is ST segment elevation. And when it come below this line, we say ST segment depression. And this is the T wave. This is the T wave. And actually, the T wave normally is the last deflection in the ventricular repolarization process. But sometimes you may find U wave. This is U wave. In some patients, you don't see the U wave in all patients. The interval from the ST segment, from the J point to the end of the U wave, this is ventricular repolarization. And the duration from the Q wave to the S wave is ventricular depolarization. If you observe carefully, usually ventricular depolarization represent about less than 1/3 of the duration of the cardiac cycle. That is to say, most of the time, or most time in the cardiac cycle is ventricular repolarization. And the summation of the ventricular depolarization and ventricular repolarization, all this interval is called QT interval. So QT interval is the summation of the ventricular depolarization and ventricular repolarization together in the ECG. So if we come to the ECG paper, if you look carefully, we have a large box and we have a small box. This is the box, the large box of the ECG paper, and it is divided into a small box. Every one small box constitute about 0.04 second if you go horizontally, and this is the time. And when we say seconds, usually you go horizontally, 0.04 second. And the large complex equal 5 small boxes. So if you multiply 0.04 second times 5, you will find 0.2 second. So the large complex equal 0.2 second in the ECG. And this is very important when you come to analyze different form of diseases that can be diagnosed by the ECG. So horizontally, one small box equal 0.04 second, and one large box equal 0.2 second. If you go vertically, one small ECG ECG complex equal 0.1 millimeter, 0.1 millivolt, or 1 millimeter, and the large box equal to 0.5 millivolt or 5 millimeters. So if we come to the rhythm strip and to analyze the ECG, we have steps. If you follow, everything will be very easy for you. So in the rhythm strip, usually it is around 6 seconds. 6 seconds equal 30 large boxes, because we say one large box equal 0.2 second. If you multiply 0.2 times 30, it will be around 6 seconds, around 6. So in a rhythm strip, which is 30 large QRS complexes, equals 16 seconds. Usually it is marked every 15 QRS complex, or every 3 seconds will be marked by, by this vertical bolt. So this is 15 QRS complex or 3 seconds, and this is another 15 complex or another 3 seconds. This will help in calculating the heart rate. So when you come to analyze the rhythm strips, step 1, you have to calculate the rate. Step 2, determine the regularity. Is the rhythm strip regular or not regular? Step 3, you have to assess the P wave. Step 4, you have to determine the PR interval. Step 5, assess the QRS complex duration. If you follow these steps, the ECG will be very easy for you. To calculate the heart rate, count 15 QRS complex, large QRS complex, 30 large QRS complex. Start from a QRS complex, which is here. You start from here, you make a bolt, and then you count 30 QRS complex, and you make another bolt. And then you count the QRS complex between these 30 large QRS complex and multiply by 10, you will have the heart rate. So start here and you end here. These are 30 large QRS complex. Then we count the QRS complex 1, 2, 3, 4, 5, 6, 7, 8, 9. Multiply by 10, you will have a heart rate of 90 beats per minute. This is very important, particularly if the rhythm strip is not regular. So if the rhythm strip is regular, you can count the QRS complex. For example, this is one QRS, this is R wave, this is one R wave, and this is another R wave. The distance between the two R wave, 300 over the number of the QRS complex. For example, this is the first R wave. If you have the second R wave here, you will do 300 over 1, the heart rate will be 300. If the second R wave is here, you do 300 over 2, the heart rate will be 150. If the R wave, the next R wave is here, then you have 1, 2, 3. So 300 over 3, the heart rate will be 100. If the next R wave is here, this is the first R wave, and this is the next R wave, you count the large QRS complex 1, 2, 3, 4. So 300 over 4, the heart rate will be 75. But you should not apply this concept if the ECG is not regular. For example, if the patient has atrial fibrillation, you should not apply this concept. So the next step, you determine the regularity. This is how to assess the regularity. You have to map the R wave to the next R wave by taking a pen and a paper, and you mark this is the R wave, and this is the next R wave, and you put it here, and here, and here, and the ECG will be regular for you. Any irregularity will be very clear from the ECG rhythm. So you have to map. Everyone should map. You shouldn't look to the ECG and you say the ECG is regular without mapping. You have to map with a paper and a pen. So this ECG is regular by mapping the distance between the R and the R wave. The third step, you have to assess the P wave. Assessing the P wave is very important in the ECG. So this is the P wave. We say the P wave is the first positive deflection in the ECG. This is the P wave. This is the P wave, followed by the QRS complex. So you have to assess the P wave. Is it there? If the P wave is there with a normal shape, a normal contour, and followed by a normal QRS complex, this is sinus rhythm. This means the pacemaker of the heart is the SA node. Is there one P wave for each QRS complex? You have to count the number of the P wave in the rhythm, and you have to count the number of the QRS complex in the rhythm. Every P wave should be followed by one QRS complex. If there is extra P wave or extra QRS complex, this means there is the problem in this rhythm strip. They should be equal. If you have 10 P wave in the rhythm strip, you should have 10 QRS complex. And every normal P wave should be followed by a normal QRS complex. And this is a normal sinus rhythm. So this patient has a normal sinus rhythm. So if we come to the abnormalities of the P wave is very important in the ECG rhythm and should be assessed every time you look to the ECG. First, you have to assess the P wave. Is there any P wave? And if the P wave is there, is it normal or not normal? You look for the contour, for the shape, for the amplitude, for the duration of the P wave. Everything in this is very important. You have to ask yourself questions. Question number one, is there a P wave in the ECG? Yes, there is a P wave. Is it has a smooth contour? Is it has a normal shape and normal contour? Yes. Is it monophasic in lead 2? We assess the P wave usually in lead 2 and lead V1. I'm not expecting someone who know the ECG go to assess the P wave in a different leads like مثلا V6, V7. No, you should assess the P wave in lead 2 and in lead V1. This is the leads where we assess the P wave. Usually you have to look to these two leads. Is it monophasic in lead 2? Usually it is monophasic in lead 2. And in lead V1, usually it is biphasic. Is it has a duration of less than 0.12 second? 0.12 second means less than 3 small boxes. Is it has a normal duration less than 0.12 second or not? This is the normal contour of the P wave in lead 2. This is lead 2. This is the normal P wave, normal amplitude, and normal duration, usually less than 0.12 second or less than equal to or less than 3 small QRS complexes. And in lead V1, it is usually biphasic. The initial portion of the P wave in lead V1 is usually due to right atrial contraction. And the next or negative deflection, usually below the isoelectric line in lead V1, is due to left atrial depolarization. So the activity in V1, usually it is biphasic. The first initial portion is due to right atrial depolarization. And the next negative deflection is due to left atrial depolarization. We say that atrial depolarization will be manifested as a P wave in the ECG. Where is atrial repolarization? We say that atrial repolarization cannot be assessed by the ECG, and usually we do not see it in the ECG. But in the ventricles, the QRS complex usually denotes ventricular depolarization, and the R wave and the ST segment usually denotes ventricular repolarization. But Atrial repolarization usually will not be assessed by the ECG normally, but can be assessed by the electrophysiological studies. So if you come to lead 2, in lead 2, the abnormality of the P wave, usually you have 2 abnormality in lead 2. The right atrial enlargement, usually you see it as a taller P wave. We say it P pulmonale, and you will see it. And in the left atrium, usually we find a notch P wave, and we call it P mitrale. And this is the P pulmonale, tall P wave, usually due to right atrial enlargement. We see it in lead 2. We see it in lead 2. Left atrial enlargement, usually you see a configuration like this. This is called P mitrale. You have a bifid. This is right atrial enlargement, and this is left atrial enlargement. So in lead 2, you will see P pulmonale, and you will see P mitrale or bifid P wave. So bivasic P wave are seen for both left and right atrial enlargement. For right atrial enlargement, the initial portion of the P wave is larger than the distal portion. And in left atrial enlargement, the initial portion of the P wave is smaller than the distal portion. So when you find a bivasic P wave, lead V1, if you find the initial portion is larger than the next portion, usually this is due to right atrial enlargement. So right atrial enlargement in conditions like pulmonary hypertension, pulmonary stenosis, and these things, the first positive portion of the P wave, we say it is bivasic. So the first positive portion will be larger than the second portion, and usually this is called P pulmonale. In left atrial enlargement or P mitrale, you find bivasic P wave, but the next portion of the P wave is larger than the first portion. And this is called P mitrale. And from this ECG, confidently we can say likely the left atrium is enlarged and the right atrium usually is not enlarged. And you will confirm this by doing echocardiography for such patient. So after you assess the P wave and you pick up the abnormalities of the P wave in the rhythm strip or in the ECG, usually we say in the rhythm strip lead 2, and in V1, you come to determine the PR interval. And the PR interval usually from the start of the P wave to the start of the QRS complex. And the start of the QRS complex usually the QRS complex start by the Q wave. Is it right? So actually it should be QT interval rather than PR interval. But usually people say PR interval, but actually it is the PQ interval. You have to calculate from the start of the P wave to the start of the Q wave. This is PR interval, and this is very important. And we have a lot of conditions that can lead to narrow PR, short PR interval, or prolonged PR interval. And if you assess the PR interval, usually it is about 3 small boxes to 5 small boxes. That is to say 0.12 to 0.20 seconds. Yani the PR interval usually it is around 1 large box in the ECG. If it is longer than this, this is prolonged PR interval. And if it is shorter than 0.12 seconds, this is short PR interval. And we see short PR interval in what conditions? Short PR interval, you see it in what conditions? In Wolff Parkinson White syndrome, you see short PR interval because we have accessory pathway that bypass the normal conduction, and the electricity from the atria jump to the ventricles through this accessory pathway, and this is called Wolff Parkinson White syndrome, and you will assess this later, or in the coming lectures. So prolonged PR interval, we see it. Prolonged PR interval, we see it in a lot of conditions. We call it bradyarrhythmias, and we will come to discuss this. Start from sinus bradycardia to first degree heart block, second degree heart block, or a third degree AV block or complete heart block. We will assess this later, inshallah. So then after the PR interval, you come to assess the QRS complex. And the normal QRS complex usually around one small box to less than 3 boxes. And usually it is around 0.04 second to less than 0.12 seconds. If there is the QRS complex duration more than 0.12 seconds, we say the QRS complex is what do you call it? Wide QRS complex. The normal QRS complex is the narrow QRS complex, usually around one small box, or two small boxes, 0.04 to 0.8, up to less than 0.12 seconds. This is the normal QRS complex. If the QRS complex is widened, that is to say more than 0.12 seconds or more than 3 small boxes, this QRS complex is wide. And we say here we have a wide QRS complex. So in this ECG, the duration of the QRS complex is 0.08 seconds, and this is normal QRS complex. So in summary of this rhythm strip, the rate about 90 to 95 beats per minute, and usually it is regular. There is a P wave, which is normal in shape and contour. The PR interval is normal in duration, and the QRS complex is normal in duration, and the interpretation of this rhythm is sinus rhythm. So this is sinus rhythm. This is the characteristic of a sinus rhythm. This is the normal. If you do not know the normal, you will not know the abnormality. Any deviation from this abnormality is called arrhythmias. Deviation from a normal rhythm is called arrhythmias. So arrhythmias is nothing, it's just a deviation from this normal, and this will be discussed later. So this is a normal sinus rhythm, and the normal sinus rhythm, the electrical impulses usually arises in the SA node and conducted normally. When we say this is sinus rhythm, the electricity arises in the SA node, which is the pacemaker of the heart, and there is no abnormality in conduction. This electricity is conducted normally to the to the ventricles, and this will be obtained by a normal sinus rhythm. So normal sinus rhythm parameters, usually the rate around 60 to 100 beats per minute. Usually it is regular. The P wave is there and normal in shape and contour and duration. The PR interval is normal, and the QRS complex duration is normal. And any deviation from the above is sinus tachy, sinus brady, or an arrhythmias. So كل الحاجات دي بنسميها arrhythmias, and this will be discussed normally. So we come to the abnormality of the QRS complex in details. Ventricular conduction defects. The QRS complex along with the ST segment analysis is very important, and usually this is very important to assess the myocardial perfusion. And if the myocardium blood supply is critically compromised, particularly acutely, this will be manifested in the ECG by certain changes in the QRS complex and the ST segments, and this will be very clear in the ECG, and it will aid in the rapid diagnosis of these serious conditions so that the treatment can be obtained early. So the QR complex is very important, and the ST segment is also important and should be assessed very accurately to assess the abnormality. As we say that this is the ST segment. The ST segment starts from the J point, and this is the ST segment, and this is the T wave. Usually, the abnormality in the QRS complex are less than the abnormality in the ST segments. Why? Because QRS complex usually denotes ventricular systole, right? Right? Is it right? Ventricular depolarization usually will be donated by the QRS complex. Ventricular depolarization. And usually ventricular depolarization, it doesn't need much energy. Usually the energy in ventricular depolarization is very minimum. So you do not find much abnormality in the QRS complex. Usually there is right bundle branch, left bundle branch, and these things. But the abnormality in the ST changes are many. A lot of conditions, myocardial ischemia, electrolyte abnormalities, myocardial injury. These things will give you a lot of abnormality in the STT changes. Why? Because repolarization of the ventricle is an ATP dependent. It is an energy dependent. And usually, if the blood supply is compromised acutely, you will have shortage in the ATP. And this will be manifested by many abnormality in the ST changes. So the abnormality in the ST segment, the first abnormality is ST depression. And this is the ST depression. This is the isoelectric line, right? The ST segment should be here in this line. So the ST segment come down. So this is called ST segment depression. And we have three forms of ST segment depression: horizontal, upward, and downward. And downward ST segment depression usually like this, downward, and upward ST segment depression like this, and horizontal ST segment depression like this. Usually the one which is likely linked with myocardial ischemia is the downward ST segment depression, followed by the horizontal form of the ST segment depression. And lastly, the upward ST segment depression, and usually very rare this to be linked with myocardial ischemia. Usually it is non-specific, and a lot of conditions can lead to this abnormality. If you come, this is actually the action potential of the myocardial cells. This is ventricular depolarization, and this is ventricular repolarization. Actually, people found it, the ST segment elevation looks very close to this shape. And usually the ST segment elevation, this is the isoelectric line. If you see the ST segment will be elevated like this and then come down. This is the ST segment elevation. And usually ST segment elevation, it denotes myocardial injury. The first abnormality that usually we see in the ECG when the myocardial blood supply is critically compromised is, what is the first abnormality in the ECG that you see it in acute myocardial ischemia, like in patients with acute coronary syndrome, when the artery is occluded suddenly and the blood supply to the myocardium is critically compromised? The first abnormality is hyperacute T wave. Hyperacute T wave, this is the first abnormality that you will see it in the ECG. And usually it will appear in hours. The first abnormality is the hyperacute T wave. And usually it is broad shape. It is broad shape. This is in contradistinction to the hyperacute T wave of the hyperkalemia, which is narrow. The base is narrow. And the hyperacute T wave of ischemia, usually it is hyperacute, tall, and the base is wide and symmetrical. This is in contradistinction to the base of the hyperacute T wave of the hyperkalemia. Usually it is hyperacute, but the base is narrow and symmetrical. Usually the ascending limb and the descending limb are symmetrical, and we will discuss this separately in the abnormalities, electrolyte abnormalities in the ECG later on, inshallah. So the first is the hyperacute T wave. Then will come the ST segment elevation. So hyperacute T wave, you see it in minutes from the onset of chest pain, and from the onset of the occlusion of the artery, you will see hyperacute T wave. This is why you should keep doing and repeat the ECG for a patient who presented to the casualty with cardiac chest pain. You shouldn't do one ECG and you stop, you say the ECG is normal. Actually, the ECG most of the time is normal early on when the patient presented with cardiac chest pain. So you should keep doing ECG, and we will discuss this in the presentation of acute coronary syndrome, inshallah. So in minutes, there is hyperacute T wave. Then in hours, there is an ST segment elevation. ST segment elevation, usually in hours, and usually after 12 hours, you will find Q wave in the ECG. But in the era of CMR or cardiac MRI, people found that sometimes Q wave will come early before 12 hours. And usually people in the past, they will say that if you see Q wave in the ECG, sometimes this myocardium is dead and the patient is already infarcted. This is in the past. But now, with the introduction of the CMR, people found that Q wave sometimes come early, before 12 hours. And when they do the CMR, they saw some variability in the myocardium. And the concept of the Q wave in the ECG denotes myocardial infarction. This concept is obsolete. So this is the ST segment elevation, and this is the Q wave. This is the Q wave, very clear Q wave. The first negative deflection in the ECG usually is a Q wave. So we will jump to assess the bundle branch block. In bundle branch block, either the right or the left branch is partially or totally blocked. So bundle branch block is very important finding in the abnormality of the QRS complex. And you will find this abnormality very frequently in the ER, and you will find it on a daily basis. If you see people or if you treat patients in clinics or in hospitals on ER, you have to be very familiar with bundle branch block because you will see it in a daily basis. So bundle branch block is very important, and normally both bundle branches depolarize simultaneously. Normally the right ventricle and the left ventricle, electrically and mechanically, this activity usually simultaneously. The right ventricle and the left ventricle, electricity will be initiated and conducted simultaneously at the same time, and you will find right ventricle and the left ventricle and the right atrium and the left atrium usually contract simultaneously. When we talk about bundle branch block, we talk about the ventricles. So if you have bundle branch block, the unblocked side depolarize first, and its impulses then spread to the blocked ventricles. So the depolarization of the ventricles is sequential, is not simultaneously. So in bundle branch block, you will not find both ventricles contract simultaneously. The major significance of a new bundle branch block is that it may indicate the presence of previously unknown underlying cardiovascular disease. So when you come to the right bundle branch block, the right bundle is blocked. So what are the conditions that cause right bundle branch block? Commonly, pulmonary embolism, chronic lung diseases, cardiomyopathy, particularly right ventricular cardiomyopathy. Sometimes you see it in dilated cardiomyopathy, that say both ventricles. And in atrial and ventricular septal defects, you will sometimes see bundle branch block. In some individual, RBB can be seen normally. Well, this is very important. Actually, see RBB or right bundle branch block in 5% of people less than 65 years. And you will see it in 1% in people more than 65 years. And I see in this part of the world, many people with the RBB, which is sometimes normal variant, are labeled as ischemic heart disease, and they're taking a lot of anti-ischemic medications unnecessarily. Also, I see many people admitted to the coronary care unit as acute myocardial infarction or acute coronary syndrome, and actually they have electrical right bundle branch block. They don't have any abnormality, they don't have any acute coronary syndrome. And so you have to assess these conditions very accurately and have to be familiar with it. If you follow certain steps in the following minutes, you will be very safe in assessing right bundle and left bundle branch block. So in right bundle branch block, you see 2R wave. You see two R wave. We say the R wave is due to ventricular depolarization, right? Ventricular depolarization simultaneously, the right and the left. But in right bundle branch block, what will come first? The activity of the left ventricle. And then the activity of the right ventricle will come later. So we will have two R wave actually, the R and the R prime. So right bundle branch block, usually Anna, I want you to understand these concepts rather than say there is M wave, there is what is called, there is these things usually is not right. You have to understand things so as to assess this abnormality in seconds. So in right bundle branch block, the R wave and the R prime are intervening with the S wave in lead V1 and V6 and lead 1. Usually when you come to assess the bundle branch block, right or left, you need only 3 leads. You look to them, lead 1 and lead V1 and lead V6. Lead 1 and lead V1. So number 1 is found in 2 leads, lead 1 and lead V1 and lead V6. You look to these leads. So right bundle branch block, this is what you see. This is, we say the right bundle branch block, the left ventricle activity come first. And this is the R wave of the left ventricle. And then the dotted R wave is the activity of the right ventricle. And actually this is what you see. First the R wave, this is the first R wave of the left ventricular activity. And the next R wave is this one is the R wave of the right ventricle activity, because we have right bundle branch block, so the right bundle will be delayed. What will come first is the activity of the left ventricle. This is the R wave of the left ventricle. And this is the R wave of that is to say the R wave is split. First portion is due to left ventricular activity. And the last portion is due to right ventricular activity. And vice versa will be occur in left bundle branch block with a minor differences. So this is called RSR. This is what you will see it in lead V1, right? This is the RSR. Yani we have two R waves. This is the first R wave, and this is the second R wave, and the two R waves are intervening by an S wave. So you will have R and R prime intervening by the S wave. This is what you call RSR in lead V1, right? Is it clear? This is very important, and we want you to understand it very clearly. So you will find a tall, wide notch R wave. In bundle branch block, because there is delay in the conduction of the activity, the QRS complex should be wide, more than 0.12 seconds. Should be 3 small boxes or more. If you do not have wide QRS complex and the pattern is the pattern of the right bundle branch block, you will say there is an right bundle branch block pattern, or you will say there is incomplete right bundle branch block, because you have the pattern but the QRS complex is not wide. But if you have a wide QRS complex with the pattern consistent with the right bundle, so this is what we call complete right bundle branch block. So in V1 and V2, usually in V1, ركزوا في V1, you will find an RSR pattern, usually more than 0.12 second, and you will find an S wave in lead V5 and V6 and lead 1 as well. يعني lead V1 and V2, usually there is an S wave, and I will show it to you. And usually there is an ST segment changes in both right bundle and left bundle. In the right bundle, there is an ST segment depression and sometimes T wave inversion in V1 and V2. In left bundle, the ST segment changes usually in the left-sided precordial leads, V5, V6, sometimes you go to lead AVL, like usually the ST segment depression usually confined to the V1 and V2 in right bundle branch block, because in right bundle branch block, the abnormality usually in the right side of the heart. We say like pulmonary stenosis, pulmonary hypertension. And in left bundle branch block, usually the pathology in the left ventricle, so the ST segment changes will be confined to the left ventricle. And this is the axis. We will talk about the axis later on. So this is right bundle branch block. Look to lead V1 and lead 1 and lead V6. This is V6. You don't need more than this. In lead 1, we say there is an RSR. Not very clear in this V1, but there is an R wave in V1 and broad shape S wave. This is the S wave. And the same shape of this S wave will be found in V6. In V6. So this is in the presence of wide QRS complexes. This is right bundle branch block. You don't need more than this. So this is right bundle branch block. Usually look to lead V1. In lead V1, there is an R wave in RBB. In lead V1, there is an S wave in LBB. يعني right bundle branch block in V1 there is an R wave. In left bundle branch block in V1 there is an S wave. S wave is down, R wave is above. So in left bundle branch block, usually left bundle branch block is almost always pathological. It is not a benign. That is to say, we don't have normal left bundle branch block. LBB is almost always indicative of underlying pathology, and you should detect this pathology. This could be dilated cardiomyopathy, hypertrophic cardiomyopathy, hypertensive heart disease, aortic valve disease, coronary artery disease, and these things. There are many abnormalities that can be picked up by LBB. That is to say, we have no benign LBB. We have no normal LBB. When you find LBB, usually it is pathological. Usually it is not benign. Usually there is an underlying abnormality, and you should look for this abnormality. So a left bundle branch block, usually you see it in lead 1, V1, and V6. And the two R waves, we say there are two R waves, R and R prime, without an intervening S wave. This is in contrast distinction to the right bundle branch block. So the R and R prime in LBB will not be intervening by an S wave. And usually you see it in lead 1 as what is called M shape. You will see the first R wave and the next R wave without intervening S wave. So very, very, very clear. So this is right. This is the R wave, and this is the next R wave. This is the left bundle branch block. This is the first R. It will not come down here to see an S wave, and then it elevate. No, this is the first R, and this is the next R, and this is called M shape. Usually you see it in lead 1. The RSR in lead V1, but the M shape in lead 1 and V6 in the left bundle branch block. This is the R and the R prime in left bundle branch block. And in left bundle branch block, the first R is due to right ventricle depolarization, and the next R is due to left ventricle depolarization. This is in contrast distinction to the right bundle branch block. The first R is due to left. The first R is due to the first R in RBB is due to left bundle branch block, and the next is due to the right. Yani usually in RBB the left ventricle come first, followed by the R wave of the right ventricle activation. In LBB the first is due to right ventricular activity, and the next is due to left ventricular activity, and this is the M shape that you see it in left bundle branch. Usually the initial R wave in V1 and initial Q wave in V6 will disappear in bundle branch block. Yani usually V1 up to V6, the R wave start by initially small R wave, positive deflection, and then it will increase gradually, and the S wave will decrease gradually. V1 with V1 small, V2 the R wave will be taller and taller than the R wave in V1, and the S wave will decrease. In lead V3, usually the R wave equal to the S wave. That is to the positive deflection equal to the negative deflection. And in this lead, this is called isoelectric lead. This lead usually you see it in V3 and V4. If it come beyond V4, you will say there is a poor R wave progression. And poor R wave progression, the isoelectric lead is not V3 and V4, usually come later. And this is called isoelectric line. So initially, in left bundle branch block, you will not see this initial R wave in V1, and you will lose the Q wave in V6. But this is very important. You have to assess it very clearly. And usually, there is a white M-shaped R wave in lead V1 and in lead V6, and the QRS complex is white, and the SC segment depression usually in V5 and V6. And this is left bundle branch block. If you look, this is the M shape, this is the initial R wave, and this is the next R wave اللي V1. Actually بتكون نفس الشكل في V6. In V6 the same. And in lead V1 you have S wave downward, not upward, right? So you look to lead 1 in LBB, you look to lead 1 and V6. You will find M shape, and you look to V1, you will find S wave. And here in lead V6, there is no initial Q wave. If you see, there is no negative deflection. The initial Q wave in V6 will be lost, and the initial R wave in V1 will be lost. In contradistinction to the right bundle branch block, this is the first R followed by the next by S wave, and then followed by the next R, which is called RSR in lead V1. And you may find this shape. You will find this shape. Sorry, this is lead 1. Usually you find S wave. But this is V1, you find RSR. This is the R intervening by the S wave, and this is the next R. The first R is due to left ventricle activity, and the next R is due to right ventricle activity. And in lead V1 and lead V6, you will find broad shape S wave. So this is LBB. This is left bundle branch block. If you look to lead V1, the M shape. The M shape, you will not see it equally. Sometimes the first will be taller than the right, and the left will be taller than the right. Well, it has very important implications in the arrhythmias. In the arrhythmias, we will come to discuss it. You have to differentiate between the typical right bundle branch block and the atypical right bundle branch block. Because in arrhythmias, particularly in SVT with apparent conduction, the right bundle, what you see it is atypical RBB. You will not find the typical. There are some changes. This will guide you to diagnose SVT with apparent conduction. So this is the M shape. If you see, this is the M shape in lead 1. And in lead V6, sometimes you find it, I will not find it. And in lead V1, there is S wave. So thank you very much. This is the end of my talk. Today, I'm very glad to have Dr. Sahar with us. Dr. Sahar is a Eva Pharma pharmaceutical company, and she is going to present to us one of very important medication in the treatment of diabetes. Dr. Sahar, please welcome. And I have to conclude this talk to allow Dr. Sahar to present her presentation. Thank you very much.